Hello, namaste students. Now we are discussing the general physical examination and how to examine the central nervous system, respiratory system, cardiovascular system and abdominal system. So with this background of how to examine the patients, the future will consider the important exam cases for both undergraduates and postgraduates in each system. Okay. So today we are discussing one very interesting central nervous system case. Okay, our student will present this case. Okay, so we'll start with the history. Okay, the patient by name X. With that she will start now. Okay, and we'll go ahead with the examination. Okay, and discussion of the history of this patient's central nervous system disease patient.
Thank you, sir. And here comes a 22-year-old male. He studied up to BA. Is a right-hander. History given by self and reliable. He presented with a chief complaint of double vision since 6 years, weakness of both lower limbs since 2 years, numbness of both lower limbs since 2 years, unsteadiness while walking since 2 years, bowel and bladder disturbances since 1 year. Coming to the history of present illness, patient was apparently normal 6 years back. One day in the evening, while talking with his family members in his home in the sitting position, then suddenly he noticed there is a complete loss of vision of the left eye, which is sudden onset and it is painless. It was happening in 2014, and immediately the next day he went to hospital and got treated for injections and all. Then later he gained vision. Then he subsided. He was normal for almost 2 months. After 2 months, he has noticed double vision of both eyes, which is sudden onset, intermittent in nature, and which is painless. And his double vision is on looking to the sides of both eyes. It's lasting for 3 years, and he is not.
Okay, Bhuvaneshwari, you are told there is a sudden loss of vision 6 years back. And then that was improved with the injection treatment whatever he has taken. Okay, and then after 2 months he developed a double vision. Okay, so sudden loss of vision, if it is there, what are the etiologies you will consider?
Optic neuritis.
Optic neuritis, very good.
Traumatic we will consider any sudden.
Central retinal artery occlusion, optic neuritis. So you consider for sudden loss of vision. Ischemic neuropathy. Okay. Then after 2 months, he developed the diplopia. If a patient comes with a diplopia, what are the questions you ask in the case of diplopia? So you will ask whether it is monocular or binocular. Okay, monocular means whether with one eye only he can see the double visions. If monocular double vision is there, the etiologies are usually within the eye itself. For example, in the cornea, astigmatism, keratoconus. Or probably there may be a problem in the iris, lens problem, or problem with the retina within the eyeball itself. That is a monocular diplopia. Whenever there is a binocular diplopia, usually the cause will be extraocular muscle involvement, ocular muscles will be involved. Then you have to ask in the history of diplopia whether patient is having a vertical diplopia or a horizontal diplopia. Whether you ask that point in the history, you have asked that. Continue, then we will discuss.
This double vision is sudden onset, intermittent in nature, and it is painless, and he has horizontal double vision, that is on looking to the sides of both eyes.
So you are telling horizontal diplopia. If horizontal diplopia is there, what you will consider? If vertical diplopia is there, what you will consider? Horizontal diplopia means that two images will occur side by side. The vertical diplopia means will occur above and below. If horizontal diplopia, what you will consider? And if vertical diplopia, what is the problem you will consider?
Horizontal means mostly cerebellar.
Oh, not like that. Horizontal means usually medial rectus or lateral rectus paralysis. Okay, horizontal diplopia. Whereas the vertical diplopia means usually oblique, superior oblique and inferior oblique will be involved. Vertical diplopia and horizontal diplopia. Okay, then you should ask in the diplopia whether it is crossed or uncrossed. Whether the two images will be crossing each other or they are not crossing each other. Okay, if they are crossed, the two images are crossed each other, then it is a medial rectus problem. If it is uncrossed, then it is a lateral rectus problem. Then what other points you ask in the diplopia?
Here it comes uncrossed.
It all uncrossed. Both are separate. Good. Nice. Then?
And associated with and it's lasting for 3 years. He has the double vision.
Continuously, it was coming and going, remission and coming and going. Intermittently coming and going, the double vision. Okay, right.
So when he got the double vision, it gets relieved when patient turns head to that side.
Head to which side?
Which side he has double vision, that side he is to turn.
Very good, nice point you asked. The double vision, whenever he has, it will reduce if we turn the head towards that side, but not to the opposite side. Suppose if there is a double vision, and if the head is, if the double vision is relieved by tilting the head towards the opposite side, what problem will consider? Trochlear nerve. Okay. So suppose if there is a right-sided trochlear nerve palsy, if the double vision is relieved with the bending of the head, tilting of the head towards the left side, then the right side trochlear nerve palsy you will consider. Okay. And one more point you should ask in the diplopia is whether diplopia is more on driving. Whenever you drive car, your eye will be divergent. It will be away. So that you get in a lateral rectus palsy while driving, the diplopia. Okay. While reading, usually it will be the medial rectus and oblique. Okay. While driving will be usually a lateral rectus. Okay. While whether you ask that point in him, tell. Driving he has diplopia. Very good.
Playing football.
Very good. So he is telling when driving and playing football. Football also he has to have a wide vision of the field. Driving also wide vision of the field. That means lateral rectus. Lateral rectus is most probably involved in it by history wise. Let us come to the examination of diplopia, which muscle is involved, how to examine. While examination, I will teach you how to look for which muscle is involved in diplopia. Okay. So these are the relevant points which you have to ask in a diplopia. Okay. Then when you will examine, we will discuss some other points in how to examine the diplopia case. Okay. Diplopia here, sudden loss of vision, 6 years back. 6 years back, sudden loss of vision. 2 months after the diplopia persisting intermittently, coming and going. Okay. Then
so he is not under treatment for 3 years almost. He have double vision. So in 2016 he has taken treatment for the double vision. He went to hospital and they have given some injections. So he was fine for 3 months without any symptoms after taking that injection. Then after 3 months again it started double vision. And it's lasted for 3 years. It's also not associated with any pain. And he has not taken treatment.
But only intermittently used to have double vision. Yes. Okay, good, nice. Then.
And after 3 years, its double vision is persisting. And then he had suddenly noticed weakness of both lower limbs, and he is not able to lift the legs while climbing stairs and not able to get up from sitting position.
That weakness, what you are telling, sudden weakness of both the lower limbs, whether it occurred during rest or while activity, while exercise?
Suddenly in the morning while activity, sir. During activity it has happened.
During activity, which activity?
While climbing stairs.
At that time, climbing stairs. Okay, not a vigorous exercise. Okay.
So
both the lower limb weakness. Continue.
Both lower limb weakness, and it is sudden onset, gradually progressive, and he is unable to lift leg to kick football, and there is not able to hold chappals.
So this motor weakness since how many days?
1 year. Sir.
Since 1 year. Okay. Can you elaborate on that motor weakness, whether proximal, distal, or both?
Yes, sir. First, initially, the weakness started in the proximal, like he is not able to get up from sitting position, and later it progressed to not able to hold chappals.
Oh, so both proximal and distal is involved. Okay.
Then there is also associated stiffness of both lower limbs.
Why this stiffness is very important, Bhuvaneshwari, in central nervous system? This whenever he has a symptom motor weakness of both the lower limbs, the stiffness is important. Why?
Because to corticospinal.
Yeah, if stiffness is there, corticospinal tract is involved. It's a UMN type of motor weakness. Okay, right. Then.
So he had noticed stiffness in both lower limbs and in the hip region. And he is unable to lift leg to kick football, and he is not able to walk in a straight line, and he is to have a drunken gait.
So there is a ataxia. Okay, there is an imbalance. Along with that motor weakness, even he noticed the imbalance. Okay. Whenever there is the cerebellar symptom like imbalance is there, any other cerebellar symptoms you asked?
Other than that, speech.
Speech you asked. Okay, then.
Is normal.
Any intentional tremor you asked?
Yes, sir. He is not having any tremors.
He is not having any intentional tremors. Okay. Only there is a imbalance while walking. Okay. Okay, right.
And after the lower limb weakness, there is a history of not able to mix the food and not able to, he can't able to buttoning of shirt. There is a difficulty in holding objects with both the hands. And there is not able to.
So you have the distal muscle weakness, the mixing of the foods, the buttoning and unbuttoning of the shirt, distal muscle weakness you asked. Whether you had any proximal muscle weakness, upper limbs, bilateral? No proximal, only distal muscle weakness is there. Okay. Any stiffness in the upper limb also?
No, sir.
No stiffness, only lower limb stiffness. Okay, right.
And patient not able to hold even spoon with the right hand, so he used to have with the left hand. And later he had history of numbness of both lower limbs, which is sudden onset, gradually progressive, and there is a decreased sensation below the hip.
Okay, there is a different sensory level you are telling. Below the hip level, he couldn't feel the sensation. What sensation he is not able to feel?
Only clothing, sir.
Clothing, fine touch. Clothing. East-wise, you will ask why the cloth if he is not appreciating, fine touch is not appreciating. Okay. When he takes bath, hot and water, cold water at that time, he can appreciate. He can appreciate. Only if the fine touch cloth is not able to appreciate history-wise. And there is numbness below the level of hip. Okay, sensory symptom. Okay,
there is
right.
also a band-like sensation around the hip region.
Band-like sensation. That indicates what band-like sensation?
Spinal cord involvement.
Spinal cord involvement, usually you get that in a compression. Compression of the posterior column, you get a band-like, girdle-like sensation around the umbilicus. Okay, right.
So this numbness also sudden in onset, gradually progressive.
So numbness is since how many days?
This is 1.5 years.
1.5 years. Okay, okay.
So after that, he is able to feel sensation of both hot and cold, and history of fall towards the back while face washing is done in the washroom. Then used to have, sir.
Oh, there's a wash basin sign. So if he washes the face, he will fall towards back side, not front side. Okay, right. Okay.
And there is
that indicates what? Wash basin sign indicates which part of the spinal cord is involved? Posterior column will be involved. Good. Okay, right.
And there is no history of neck pain.
Why you ask neck pain history?
Because a Lhermitte
Lhermitte symptom is whenever the patient bends down, okay, there will be electric shock like sensation along the spine and both the hands and both the legs. That is Lhermitte sign. Okay. You get Lhermitte sign in which conditions?
One is multiple sclerosis.
Then?
There is cervical spondylosis. And is subacute command.
You get okay, the Lhermitte symptom due to the hepatic conduction of the demyelination fibers. For your interesting purpose, there is one more called as a reverse Lhermitte sign. Okay, in nitrous oxide exposure, where you get the electric shock like sensation from below the leg and it goes to the upper limb. And in a cervical cord compression, sometimes you extend the neck instead of flexing the neck, you get a electric shock like sensation. This is reverse Lhermitte sign. For interest purpose, you can just know it. Okay, so he is not having any neck pain and no electric shock like sensation. Okay, right then.
And later he noticed there is a history of he is not able to sit on chair without support after the numbness.
Okay.
But he can able to turn his body from one side to other in lying down position. And there is a history of incomplete evacuation of urination. There is a urgency present, and there is a history of urinating on the way while going to the washroom.
So there is no control. So what type of bladder is this according to you? Human bladder. So the precipitancy is there. There is a dyssynergia between the cortex and the detrusor. It precipitates. Urine is evacuating by itself. Hesitancy and precipitancy goes in favor of a bladder involvement. Good, nice. Then. In an element bladder, there will be a overflow incontinence. There will be a residual volume will be increased. So urine will fill and then it will overflow incontinence. Whereas hesitancy and precipitancy is a feature of human bladder. Okay.
And there is a history of constipation.
Constipation. Okay, very good. Nice. Then.
And there is no history of excess sweating, no history of any vomiting. No history.
Why you have excess sweating and vomiting?
Autonomic features.
Autonomic features of vomiting. Okay.
And there is a cranial nerve history. There is no history of any loss of smell. There is history of double vision. There is no history of drooping of eyelid. No history of numbness over face. No history of difficulty in chewing.
Instead of numbness over face, you should have asked a lancerating pain over the face. Why that history was important if at all in this case?
Trigeminal neuralgia
is a feature probably, so you should have asked for any lancinating pain over the face. That will be again discussed in cranial nerve examination. Okay, why year 2, what are the things you will expect in that. Okay, fifth nerve then.
and no history of difficulty in chewing.
Okay.
No history of drooling of saliva or deviation.
So no facial nerve weakness. Okay, nice. Then
No history of hearing loss or ringing sensation.
vertigo and hearing loss. You have to ask vertigo and hearing loss. Okay, it is not there. Then
No history of nasal regurgitation.
okay, the 9th, 10th you ask dysphagia, nasal regurgitation and hoarseness of voice. It is not there. Okay, right, good.
And there is no history of difficulty in moving head side to side. No history of difficulty in moving borders from side to side.
Okay. So 12th and 11th also not involved.
And there is no history of vomitings. And after he has taken treatment, he has taken Ayurvedic treatment for 1 month. And it was not improved. Then he was taken from other hospital. After the treatment, there is improvement in vision, walking, weakness, numbness. All symptoms have been improved since last 10 months.
Okay.
And there is no history of any seizures, no history of trauma, no history of fever, no history of headache, no history of loss of consciousness, and no history of speech disturbances.
Why you ask all those things? Headache, fever, loss of consciousness.
One thing is raised ICT signs.
Raised ICT. Okay.
To differentiate, because these are the doubtful signs.
Okay, we'll discuss that. Okay, what are the doubtful signs, the disease which you are thinking? Will after the discussion of the history, will come to that point. Okay, right. Then
And there is history of swaying to one side while walking.
now also
No, now also it's there.
east face.
Well, normally if he walks, is not help.
Tandem walking.
But if he walks in a straight line, now there is imbalance.
Imbalance is there. Towards which side he falls?
Now both sides is
Both sides he falls. Okay, nice. Okay.
Coming to past history, is no comorbidities and no history of epilepsy, no history of tuberculosis in the past. Come to family history, is family history not significant. No other members in the family are not having any of these features.
In the history, you should have asked whether these symptoms, what all he had, whether it used to get exacerbated with emotional lability, with emotional stress, or with exercise, or with taking hot bath, or drinking hot milk, or a hot substance while drinking. So, and exercise, whether these symptoms would have aggravated, or any previous history of vaccination you should have asked. The relevant to the disease which you are thinking probably here at the end of examination, whether these symptoms would have been exacerbated with any fever, taking hot bath, doing exercise, or emotional stress. And even past history of vaccination also you should have asked in this case. Okay.
So coming to the history, there is no increase of symptoms or worsening when exposure to temperature or fever.
It's not there. With fever, increased temperature, these symptoms are not exacerbated. Okay. What it is called as, if the symptoms are exacerbated with taking hot drinks or hot bath, is optic neuritis symptoms or motor weakness symptoms, if it exacerbates, what it is called as? Utah phenomena. Okay, right.
And come to treatment history, last he has taken treatment in the month of February, after that he has stopped. So come to surgical history, there are no surgeries. Personal history, takes mixed diet. As of now, bowel and bladder habits are normal. There is no high risk behavior.
In the history, even some points which were left, I want to put there. In optic neuritis, something they'll have like phosphenes. Phosphenes means, so it is a flashes of light and black colored squares in the eyes. They'll get that. So that point you should have asked. Okay. Whether flashes of the light and dark squares you will get. And what is Pulfrich effect in optic neuritis?
Temporal disparity between the two eyes.
The latency will be different between two eyes. Because the difference in the latency of the two eyes, you will have a disorientation in the traffic. That is a Pulfrich effect. So that point also you could have asked in the history for optic neuritis. Okay.
Conclusion.
Yeah, now you have taken a detailed history. Now, how do you analyze a CNS case? You have taken all the history, whatever the points he is having. First is anatomical localization, then the pathology, then tell the diagnosis. Now, what are all the deficits he has now? You tell what are the anatomical localization you want to point it now one by one.
Bladder involvement.
No, come from top to bottom.
Corticospinal tract
No, B1 before that. What here?
Optic nerve.
So second nerve is involved. So there is a optic nerve. Second nerve is involved. First, next.
3, 4, 6 cranial nerve.
Yeah, there is a diplopia. Third, fourth, and sixth cranial nerves are involved. Third, fourth, and sixth. Second, optic nerve is involved. Then,
After that, the corticospinal tract.
why corticospinal tract in the history you are telling?
Stiffness of the lower limbs.
Weakness. So there is a motor weakness of both the lower limb, and then there is a stiffness. The weakness is due to corticospinal tract because stiffness is there. Okay, and then
Posterior column involved.
why posterior column?
Wash basin sign is positive.
Correct.
Is not able to feel
Fine touch. You are not able to appreciate the fine touch, and there is a wash basin sign. So posterior column is also involved. Okay, then.
And cerebellar is involved.
Cerebellar, he told he has a difficulty while walking, swaying now also towards either side, right and left side. So cerebellum is involved. Cerebellum is involved. And you are telling ball and bladder is also involved. If ball and bladder is involved, where you want to localize? In the CNS, spinal cord. Spinal cord above the level of S2, S3, S4, because it is a human bladder you are thinking here. So above the level of S2, S3, S4, spinal cord is involved. Okay. So these are all the anatomical sites involved. Okay, optic nerve, third, fourth, sixth cranial nerve. Okay, and then corticospinal tract. Okay, and then ball and bladder is involved, spinal cord is involved, sensory systems, posterior column is involved, cerebellum is involved. These are all the anatomical sites which are involved. What is the pathology you want to consider in him?
Demyelination.
Why demyelination?
One thing is subacute onset.
Okay.
And over years, big engage.
Okay. One important thing which is having in the history.
There is a relapse.
Correct. The symptoms are coming and going. The diplopia is coming and going. The weakness is improving and it is coming and going. Even ataxia sometimes it is coming and going. Optic neuritis resolved. Okay, it is relapsing and remitting. Relapsing and remitting. Okay, that is one thing. That's why you are considering demyelinating. Okay. Dissemination in space, dissemination in time. Dissemination in space. There cranial nerves are involved, spinal cord is involved, cerebellum is involved, corticospinal tract is involved, posterior column is involved. Dissemination in space. Dissemination in time. Each attack should last for 24 hours and the gap between two attacks should be more than 30 days. That is dissemination in time. So, so many attacks coming and going. So, dissemination in space and time, that is the hallmark of multiple sclerosis. So, you want to think demyelinating disease, that to multiple sclerosis. Multiple sclerosis. With the history, they are not examined, just with the history you have come to this conclusion. Okay. What are the paroxysmal symptoms which you should have asked in the history in this case? Now, you are thinking multiple sclerosis. What are paroxysmal symptoms and what you should have asked in the history? Paroxysmal symptoms. Very good. Very good. Correct.
In facial palsy, but there will be difficult, like idiopathic Bell's palsy only, but they will not have any loss of taste sensation.
Okay, facial nerve weakness, trigeminal neuralgia, then eighth nerve vertigo, deafness, okay, then even bowel and bladder involvement, Lhermitte's sign, and ataxias, paresthesias, pain. These are the paroxysmal symptoms what you get in a multiple sclerosis. Paroxysmal symptoms are usually, they last for 10 seconds to 2 minutes. They can occur from 5 attacks per day till the 40 attacks per day they can get it. 5 attacks to 40 attacks per day they can attack. Each attack will last for around few seconds only and they subside without producing any deficits. Don't have any deficits. They won't have any loss of consciousness, EEG will be normal and they recover paroxysmal symptoms. So, any case when you are suspecting multiple sclerosis, you should have asked for a paroxysmal symptom in the history. Okay. Now, you ask such a detailed history and you analyze the history. Okay. In the history wise, now you tell what are the points which should, if it is there, it is unlikely a multiple sclerosis in history wise. Fever.
Vomitings,
loss of consciousness,
drowsiness,
coma, isolated dementia, okay, then Parkinsonism like dystonia, okay, chorea, Parkinsonism feature, correct. Severe muscular atrophy and peripheral neuropathy, correct, then seizures, correct, seizures, progressive from the onset. Progressive from the onset. If the deficit is just localized to the brain stem, spinal cord and posterior fossa, or if the patient never experienced the eye symptoms, bladder symptoms and sensory symptoms, then also it is not multiple sclerosis. And atypical investigation features, MRI is not showing anything, evok potential not showing the proper, the typical feature of MS. Investigation showing atypical features, that also rules out multiple sclerosis. The symptoms coming within minutes, that also rules out multiple sclerosis. The symptoms of cortex like agnosia, apraxia, that also rules out multiple sclerosis. Okay. Age less than 15 years, more than 60 years. Again, it should not be multiple sclerosis. These are the points which you should think it may not be multiple sclerosis. Okay. Again, in the history wise, some other point which you should have asked is, it can affect cognition. So, any memory disturbance is there, any cognitive disturbance you should have asked, and fatigue and depression also. That point you should have asked. Fatigue, depression, memory disturbances, cognitive impairment in a multiple sclerosis.
He had some forgetfulness.
He had, that point you should have told.
1 year back he had forgetfulness. So he names and all when he even tells means after few minutes, 5 to 10 minutes, if he asks again.
So there was a memory disturbance. Is a feature. Cognitive disturbance can occur in multiple sclerosis, but isolated dementia, if it is there, that unlikely in multiple sclerosis. Okay, good, nice. So those are the paroxysmal symptoms and other symptoms which we should suspect it should not be a multiple sclerosis. Those points also you should ask in the history. Okay, good, nice. Continue.
Coming to general physical examination, he is conscious and oriented. Height is 5'4" and weight is 51 kgs. Coming to vitals, temperature is normal, pulse is 78 per minute, regular rhythm, normal volume and character, no radio, no radiofemoral delay. All peripheral pulses are felt. Condition of the vessel wall is normal. Blood pressure 120 by 80 millimeters of mercury in right arm in supine position. Respiratory rate 18 per minute and abdominal thoracic type. There is no pallor, icterus, no sinus.
Slow.
No clubbing, no lymphadenopathy, no pedal edema. There is no raised CVP. Come to head to toe examination, he is moderately built and narrow. There is no xanthomas or xanthelismus, no chest wall deformities, no marked features. There is no signs of tuberculosis or HIV, no neurocutaneous markers. Coming to, so I want to go ahead with the central nervous system.
Okay, now we'll come to the proper central nervous system examination. In the general physical examination, you have not got any points which is favoring your diagnosis. Okay, it is almost normal. Okay, so let us come to the central nervous system proper examination. Okay, right.
Come to higher mental function.
What all you are checked in the higher mental function in this case, relevant to this case?
Mini mental status examination.
How much he has scored?
30, sir, 30 out of
30 out of 30, very good. So, students, we have discussed how to look for a mini mental status examination in the examination of central nervous system. All the what questions you should ask, how much point you should give. So, our student has examined in him and he has scored 30 out of 30. The normal range is 24 to 27, as I told, it depends upon their educational level. So, mini mental status examination is important in this case, okay, because they can have memory disturbance, they can have a cognitive disturbance which can produce in a disorientation, orientation problem and memory disturbance. Okay, you have done MMSc, good,
Yes,
nice.
Coming to cranial nerves examination, smell it is normal.
You examine the first cranial nerve, it is normal. Okay, right.
Coming to second cranial nerve,
Second,
visual
okay.
acuity is normal.
Now it is normal. Whether he had a visual acuity problem before when he had, you told 6 years back he had a sudden loss of vision. Then after injection totally improved, or in between whether he had episodes where the acuity was reduced?
No, sir, not there.
Not there.
Acuity didn't have any problem.
Never he had. The blurring of vision you told so many times he had.
Only complete loss of vision, that is followed by later double vision. There is no blurring.
There is no blurring of vision. Okay, right.
And visual field is normal. Pupil reactive to light.
Yeah, in this case, you are thinking, for example, optic neuritis is there. What test you do bedside to detect optic neuritis? You demonstrate. Ali, can you please sit? Suppose if left side optic neuritis is there, which bed test you do to detect optic neuritis?
Fundus examination.
Fundus you can do. Fundus will detect the optic neuritis by ophthalmologist. As a physician, what test you do to detect optic neuritis? Have you heard of Marcus gun pupil, Marcus gun test, swinging flashlight test. Will you bring the torch? So swinging light test, okay, Marcus gun sign, okay, Marcus gun pupil. Suppose left eye optic neuritis is there. Normally, if you throw the light to the left eye, the pupil should constrict. But here there is a left optic nerve is a problem. It cannot carry the impulse. So the pupil won't constrict. And if I throw the light to the right eye, it will constrict because the right eye is normal. If I throw back the light again back to the left eye, then it should have constricted, but instead of constriction, it will dilate. 2 to 3 seconds you have to hold the torch and you have to swing the light between right and left eye. Now he is in a remission phase. Both the eyes, eyelid, pupil is constricting. Swinging light test. It is a very important bedside test to detect the optic neuritis. Okay. So second optic neuritis, if you are thinking, you have to do that. One more optic neuritis, there is scotoma, central scotoma. Scotoma means there will be a loss of vision in one particular field. Surrounding field will be normal. That is scotomas. There are central scotomas, optic neuritis patients. Then other thing is loss of vision. Then Pulfrich effect we discussed. These optic neuritis symptoms can be increased by taking the hot milk or increasing taking the hot bath also. That is a Utah phenomenon. Okay. So 20% of the patients will come with the optic neuritis symptoms in a multiple sclerosis, and he is one among them. His presentation symptom was optic neuritis. And 40% of the patients will have optic neuritis during their course of the disease. 20% will be the presenting symptom. He had optic neuritis as a presenting symptom. What are the other causes of optic neuritis? One is multiple sclerosis, then
Retrobulbar neuritis.
Okay, retrobulbar neuritis. In retrobulbar neuritis, patient cannot see anything. Your doctor also cannot see anything because fundus will be normal. Retrobulbar neuritis. What are the causes of optic nerve neuritis or retrobulbar neuritis? Actually, in multiple sclerosis, the most cases are retrobulbar only. Not a optic neuritis, it will be retrobulbar only. What are other causes? For example, INH, ethambutol, toxic drugs, methyl alcohol toxins, with B12 deficiencies. They all can produce optic neuritis. Okay.
Coming to the fundus examination,
So visual acuity, fundus, field, then total reflex.
and fundus is normal.
Fundus is normal now because he is in remission.
And color vision is normal. And come to 3, 4, 6 cranial nerve examination.
Yeah, in this case, 3rd, 4th and 6th cranial nerve, what are the things you will examine?
I think is
Diplopia. Okay. So you ask in the history what type of diplopia he has. You told it is uncrossed and it is horizontal diplopia. Okay. So diplopia rules are there. Okay. So right now he has diplopia. He is in remission. He is not having diplopia. Okay. So diplopia, there are 3 rules. The rules of diplopia. The 2 images, whatever he sees, they will be maximally separated in the direction of the action of the weak muscle. That is number 1. The rule number 1 is the 2 images will be separated maximally in the direction of the weak muscle. That is the first rule. The second rule is the outer image is the abnormal image. The outer image is the peripheral image is the abnormal image. For example, if you see index finger or middle finger, the middle finger will be a blurred one. That will be the abnormal image. The third rule is this abnormal image comes from the abnormal eye, abnormal muscle. These are the 3 rules. Okay. The first rule is the 2 images will be separated farthest in the direction of the action of the weak muscle. The second rule is the outer image is the blurred image, that is the abnormal image. The third rule is this abnormal image comes from the abnormal eye or the muscle. These are the 3 rules of diplopia. Now, what are the 2 tests you do to detect which muscle is involved in diplopia? You know? Cover test and red glass test. I will explain what is cover test and red glass test. For example, now I am seeing 2 images while looking towards the left side. 2 images while looking towards the left side. For example, if I am seeing, this can be either due to a right medial rectus or left lateral rectus. The problem can be either due to a right medial rectus or the left lateral rectus. Okay. Now, if I cover the right eye, if the true image disappears, the problem is in the left lateral rectus. So, for example, if I cover my right eye, if the blurred image disappears, then the problem is in the right medial rectus. This is a cover test. Red glass test is, for example, I will wear specs where one eye will have a red glass, other eye will have a normal glass, the normal color. For example, if right eye is having a red glass, I am wearing. Now I am having a diplopia by looking towards the left side, For example, if the blurred image is a red color, because red glass is in my right eye, so right medial rectus is the problem. Okay. Suppose if the blurred image is a white color one, and suppose if I am looking towards the left side, if I am wearing a red glass towards the right eye, and if the peripheral image is a red one, the right medial rectus is the problem. Okay, this is a red glass test. These two tests I have explained even while examining the cranial nerves in the general physical examination of the central nervous system, cranial nerves also. Cover test and red glass test. Simple test. Just put a red glass to one eye, two images will be there. The red glass which is having that eye, if that image is that color, then that muscle will be involved in producing the diplopia.
And there is a horizontal nystagmus, both eyes. It's beating towards the side of the
Now also is there?
Yes, now
Demonstrate. Very good. Demonstrate.
I'll just follow the turn in the head. This is the
Okay. Okay. Now also is there. Towards left. Okay. Vertical gaze.
There's no nystagmus in the vertical case.
Okay. Right. Good. So nystagmus is there. Okay. So nystagmus can be physiological, pathological, or it can be a pendular or a jerk nystagmus. Okay. Or it can be central or peripheral. Here you are thinking central or peripheral? Central only. Probably MLF is involved or cerebellum is involved. You are thinking like that. Okay, right. The physiological nystagmus you get in extremes of the eye deviation, that is nystagmoid movement. Another physiological nystagmus where you get is optokinetic nystagmus. When you travel in a train, your eye want to fix it. That is optokinetic nystagmus. Then one more physiological nystagmus where you get is if you put a hot and cold water to the ear, then there will be nystagmus towards the cold opposite side, warm same side. These are the three physiological nystagmus. Then pendular and jerk nystagmus. Pendular nystagmus is amplitude will be equal on both the direction. Jerk is one side there will be a slow component, another side there will be a fast component. That is a jerk nystagmus. For all practical purposes, the pathological reflexes are usually, the pathological nystagmus is usually jerk nystagmus. Pendular will be rarely pathological. Okay. Now then central and peripheral. As you told, central causes or cerebellar or some brainstem causes, there are central causes. There are some differences between central and peripheral cause of nystagmus. Can you tell what are the differences, central and peripheral cause of nystagmus?
And fixating the gauge.
Fixating the gauge, the peripheral nystagmus will disappear. Correct, one difference. Then, see, there are something called as latency, habituation, reproducibility. Latency is, for example, peripheral nystagmus, if you get in a vestibular apparatus problem, okay, you put in one position, then they develop nystagmus, but it takes time to develop. That is latency. Latent period will be there. In central nystagmus, no latent period. Immediately, you add a nystagmus, no latency. Then habituation. If you keep on doing it, the peripheral nystagmus fatigues. The intensity reduces. But the central nystagmus doesn't fatigue. And you can reproduce how many times you want central nystagmus, but not the peripheral. Reproducibility is less. It becomes less in a peripheral nystagmus. Okay. Then just some points about the other types of nystagmuses. The congenital nystagmus is usually will be horizontal, and whichever gaze if you ask the patient to look, it remains horizontal. So that is not gaze evoked congenital nystagmus. Whereas the cerebellar nystagmus and a drug-induced nystagmus is horizontal nystagmus and it is gaze evoked. That means in primary position it is not seen. If you move in the other direction, nystagmus will come with the gaze. That is gaze evoked nystagmus. There are some rare nystagmuses like convergent retraction nystagmus. What happens is all the muscles will start contracting and then the eyeball will retract and eyeball will converge due to medial rectus action. So convergence, retraction nystagmus you get in upward gaze. You get in that in pinealomas, convergent retraction nystagmus. Seesaw nystagmus you get one eye will be go upwards and intorsion, other eye will become downward and extorsion. Seesaw nystagmus you get in craniopharyngiomas. Upbeat nystagmus in midbrain lesions you get, downbeat nystagmus you get in the medulla and the brainstem lesions. The lower medulla, downbeat nystagmus, midbrain lesions you get a upbeat nystagmus. Spasmus mutans is a homework. You can find it. What is spasmus mutans? What type of nystagmus? Where you get that? Torticollis, head nodding and nystagmus. Very good. Torticollis, head nodding. 6 to 12 months of age you get that. Spasmus mutans. The nystagmus will be horizontal in a vestibular, okay, vertical, horizontal in a cerebellar, rotator in a vestibular, okay, vertical in a brainstem, the nystagmus. Here he has a nystagmus horizontally. In a vertical gaze he had nystagmus, only horizontally he had nystagmus. Okay. Then you told diplopia, the previous discussion. What are the cause of diplopia in multiple sclerosis?
One is 6-nerve palsy.
Common is a 6-nerve. You told he had a diplopia while driving. While driving he had a diplopia, that is 6-nerve palsy. Common is 6-nerve. Then what are other cause of diplopia in multiple sclerosis? Very good. MLF damage can produce diplopia. Very good. Then third and fourth paralysis. Third and fourth cranial paralysis producing diplopia is rare in multiple sclerosis. Sixth is the common. What he has while driving he has diplopia. And MLF. Okay. MLF usually it is named according to the adduction failure. If the right MLF is damaged, right adduction will be a failure. We cannot adduct the right eye. But the nystagmus will be present in the left lateral gaze. It is also known as dissociate nystagmus, MLF nystagmus. It is also known as dissociate nystagmus. If one side MLF along with that PPRF is damaged, what it is called as? One and off syndrome. The only movement possible is the contralateral left eye. 8 and off syndrome is 7 nerve with the 1 and off syndrome is 8 and off syndrome. So MLF, 6th, 3rd, 4th all can produce diplopia. So in 3rd, 4th and 6th in this case, diplopia and nystagmus examination is very important. Okay, good. Students, this patient nystagmus video, even I have given 2 separate clips. You can go through the nystagmus clip. Okay, when it will be added to this topic in the course.
Coming to 5th nerve examination, we can touch sensation on the face is normal, corneal reflex is present. So
touch, pain, temperature on the face is normal, both right and left side, ophthalmic, maxillary and mandibular division, not affected. Okay, right then. Corneal reflex?
Normal, sir.
Normal. What is the afferent different for corneal reflex?
5 and 7.
Yeah, 5th is the afferent, 7th is the efferent. Correct.
And coming to 7th.
5th nerve, what you expect in multiple sclerosis? What symptom you expect in multiple sclerosis?
Lancinating pain.
Trigeminal neuralgia. How do you distinguish a trigeminal neuralgia of multiple sclerosis from a idiopathic trigeminal neuralgia?
One is in the sometimes they will have bilateral.
Yeah, multiple sclerosis trigeminal neuralgia is bilateral. Correct then? Young age. Correct then?
Objective sensory loss.
Yeah, if you examine, there will be a loss of sensation, objective sensory loss, and paroxysmal pain won't be there in a multiple sclerosis trigeminal neuralgia. Constant pain will be there. These 4 things will distinguish idiopathic trigeminal neuralgia which occurs at a old age group from a multiple sclerosis trigeminal neuralgia. Then there are some features in trigeminal neuralgia which indicates if you do a MRI, there will be abnormal imaging. Probably it could be a tumor, a vascular anomaly or a demyelinating plaque. What are the things which indicates abnormal imaging will be there? If there is a symptom progression for 1 year, then there will be abnormal image. If there is an objective sensory loss, then also there is a chance there will be abnormal imaging. Or if there is associated CNS findings are there, then also there is a chance there is abnormal imaging will be there. Symptom progression, associated CNS findings, abnormal imaging, and symptoms if it is less than 1 year. In these scenarios, usually if you do MRI, you will find some lesions. Some lesion will be there in MRI. Okay, that is trigeminal neuralgia, 5th nerve in multiple sclerosis.
Come to 7th cranial examination, it's normal.
What do you expect 7th cranial nerve in this case?
Idiopathic Bell's palsy.
Yeah, they can develop a facial nerve paralysis and even facial myokymia. Myokymia means the contraction of the fascicle muscle fascicles, myokymia. You can get that, and facial nerve weakness they can get. Correct.
Coming to 8th cranial examination is Rennes is positive, Weber's equal on both sides.
So normal, Rennes is positive, Weber's equal on both the sides. I explained detailed students in the examination of CNS how to do Rennes, Weber's and ABC test. In this case it is normal, so let us not go detail into the Rennes and Weber's test here. And what deficit you expect in MS are relevant to 8th nerve? What they can develop because of 8th nerve affection? They can develop vertigo because of 8th nerve involvement. They can have deafness. Okay.
Coming to 9th and 10th cranial examination, it's normal.
Normal. Gag reflex is normal. You examined it. Okay. What they can have? Multiple sclerosis patient, 9th and 10th cranial nerve, if at all, if they have. Correct. Like trigeminal neuralgia, even they can develop glossopharyngeal neuralgia. That is one symptom of multiple sclerosis, if at all, if there. And 9th and 10th cranial nerve, dysphagia. But dysphagia as a presenting feature in a MS is rare. Dysphagia as a presenting feature in MS is rare. Okay.
Come 11th cranial examination, he is able to shrug shoulders, can move head side to side and flex against resistance.
Okay.
And 12th cranial examination, there is a tongue tremors it is present, but there is no deviation.
How do you look for tremors? How do you look for fasciculations?
Tremors, we ask the patient to keep tongue
out.
Fasciculations means inside of the mouth.
Here tremor is there. Yes. Demonstrate.
Keep your tongue out, protrude completely.
Fine tremors are there. Fine tremors are there. Is it tongue will be focused? Okay. Yeah. Okay.
Coming to the motor system examination. And come to nutrition. Upper limb, right side arm it is 24, left 24, forearm 22.5 centimeters, left 21.
Good.
Lower limb, thigh 47 on the right side, left side 45, leg 30 centimeters and 29 on the right side.
Nice.
Tone, upper limb and lower limb tone is normal.
Normal tone. Okay. Yeah, he had a weakness 3 years back. You told there is a motor weakness, stiffness. If at that time, if you would have examined, what would have been the tone? Hypertonia. A human type of paralysis you would have expected on spasticity. Okay, right.
And come to power, upper limb and lower limb power, it is 5/5.
Now it is normal. So all the muscles you have examined, all the joints, upper limb and lower limb power is normal. Okay, right.
And hand grip is 100%.
Okay, right.
Coming to coordination, it's normal.
Coordination and cerebellum, both you examine now only. Tell me.
Finger nose test, rapid alternating movements you can do. Heel shin test.
Rebound phenomena, Ohm's rebound phenomena. Yeah, is there. Pendular knee jerk is not there. Not there. Okay. And what other cerebellum you examine top to bottom? What are the things you examine cerebellum system top to bottom? You tell. Titubation then.
And dysmetria, dysynergy.
While doing a finger nose test, you have to look for whether synergy is there, smoothness of movement is there, that is synergy. Dysynergy, if it is there, you will look. Then dysmetria, whether the finger will pass pointer, you will look. Okay. Then nystagmus also you should look in the top to bottom. Okay. Then dysarthria. What is Charcot's triad in multiple sclerosis?
Nystagmus, intention tremors and ataxia.
Intentional tremor, nystagmus, and then scanning speech. Okay. Scanning speech, nystagmus, intentional tremor is Charcot's triad in multiple sclerosis. So there is no dysarthria here. No, right or no dysarthria. Nystagmus is there. Okay. Then any intentional tremor?
No, sir. No.
You have checked for that. Okay, intentional tremor is not there. Okay. Then what other cerebellum examined you examined? Because history was you told on point. That's why I am asking.
If he walks normally, it is fine. But on his right line, he needs to have
tandem walking is a problem. Can you make him walk on shoe? Ali, can you walk on a straight line from here to there? Yeah. Yeah. Okay. Enough. So tandem walking he has a problem. He's swaying both towards the right side and left side. Okay, that's nice. Correct. Then what other cerebellar signs you can look apart from these things? Handwriting, macrographia will be there. Then chair you can keep and ask the patient to go clockwise and anti-clockwise. Whichever side there is problem, we tend to fall towards that side. Cerebellar system examination. Good, nice. Then
Next, coming to the reflexes, superficial reflexes, corneal, conjunctival as normal, present on the right and left side, abdominal reflex present.
What do you expect abdominal reflex in multiple sclerosis if you would have had a corticospinal tract weakness?
Absolutely.
That is earliest to last. In multiple sclerosis, abdominal reflex is the earliest to last.
And cremastic reflex present. And plantar is extensor.
Now also extensor. Can you demonstrate? Can like that? Elicit Babinski. Classic extensor. Classic extensor. Very nice. Good. Yeah, elicit bicep, tricep, brachioradialis. Do that because they can focus there. It's not elicitable, okay. Okay, brachioradialis. Just give a tap on the stylomastoid process. Yeah, here you tap it. Do knee and ankle check. Ilman budi. Ilman. Yeah, elicit. It is exaggerated. Exaggerated. It is exaggerated. Once exaggerated, even you should look for a clonus. Later you look for clonus after ankle reflex. Elicit ankle reflex. Exaggerated. ಬರ್ತಾ ಇದೆ ಅಲ್ಲ ಇದು? Okay. Elicit ankle clonus and knee clonus. Come this side. Give me. No problem, no problem. Do like that. No, that I'll do it. Come this way. So do a sudden jerk. It is not there. Let's see ankle clonus. You have to hold like this. No, it's not elicitable. That's not elicitable. Yeah. So you elicited the superficial reflexes and deep tendon reflex. Okay. So students, you all saw bilateral plantar extensor, but is not having symptom at all. This is a classic thing in multiple sclerosis. That will be symptom only one side, but you may get sign on both the sides. Or there may not be symptom at all, but you may elicit the sign. Here there is no moderate weakness, but plantar extensor. Or one side you may be weakness, but bilateral you may get extensor. Symptom may be on one side, signs you may get on both the sides. Here you saw bilateral plantar, beautifully you got extensor reflex both the sides. And there is exaggerated reflexes of the knee jerk and the ankle jerk, which indicates it is corticospinal tract is still involved, though he is not having any symptom. That is a sign.
Next, sensory system examination, superficial sensation, pain sensation.
After reflexes, you could have told about involuntary movements. Any involuntary movements? Yes? No involuntary movements. Okay. Now go to sensory system examination.
So coming to superficial sensations, pain sensation for pain is normal, temperature and fluid touch is normal. Deep sensation.
Fine touch is normal. Then pain and temperature is also normal. In all the dermatomes you have checked from C2 till the S2. Okay, good.
And there is a deep sensations. There is a vibration is decreased on the right side, sir. Right lower limb.
Right lower limb. From which?
Medial malleolus it has decreased.
Only right medial malleolus vibration is reduced. Okay.
Joint position is normal.
Okay.
And come to cortical sensations is normal. 2-point discrimination, tactile localization, stereognosis, graphization.
Good.
So coming to the gait, there is a tandem gait. If the
ataxic gait. See, it is an ataxic gait. Okay. So different types of gait are there. Circumflexion gait in hemiplegia, Parkinson gait where the fascinating gait will be there. Then you get waggling gait in proximal muscle weakness, high stepping gait in peripheral neuropathy. This gait is ataxic gait. Is imbalance both towards the right and left. That too only in tandem. This is an ataxic gait.
And skull and spine is normal. Autonomic nervous system examination, no portion hypotension, no tachycardia, no sweating. The system examination, respiratory system bilateral normal.
Only positive findings you tell.
Normal respiratory, cardiovascular, pyrotonics, no abnormalities.
So other systems are normal. Okay. At the end of examination, what are the positive findings you got? You enumerate.
One is nystagmus of the both.
Nystagmus. Okay.
And other increased deep tendon reflexes exaggerated, lower limb deep tendon reflexes, and there is a plantar extensor and decreased vibration on the right side, lower limb.
Okay. So after the examination, you could localize in nystagmus is there. It could be third, fourth, sixth, or MLF maybe a problem. And there is a deep tendon reflex exaggerated knee and ankle. So bilateral corticospinal tract is involved. Plantar is extensor. Again, bilateral corticospinal tract is involved. Right now, he has any bladder and bowel symptom? It is there. It is not there. Not there. Okay. At that time, I had a human bladder. You told constipation. What are? Why they have constipation? Multiple sclerosis patient. One is a neurogenic bowel. Okay, neurogenic bowel is a one cause. Another is the immobility. They may not be moving and decreased fluid intake. These are the cause of constipation in multiple sclerosis. Okay. So symptom, he has a lot of symptoms in 6 years. Signs you got around 3 or 4 very cardinal signs you got it. At the end of examination, at the end of it. Now can you come to a conclusion and give a diagnosis?
Functionally, there is a human type of weakness, lower limb weakness is there. And anatomically involvement of dorsal columns, corticospinal tracts, cranial nerves,
cerebellum,
bilateral cerebellum.
So it is a dissemination in space and in time also, not relapsing and remitting. So it's a classic case of multiple sclerosis. Here, other diagnosis doesn't arise only. It is such a classic case. He has remission and exacerbations. Multiple areas are involved, multiple time, dissemination in time and space. A classic case of multiple sclerosis. The age of onset, other clinical features, everything fitting into multiple sclerosis. Okay, right. How do you proceed?
So first we get the CSF analysis, MRI.
Which is go by the cardinal investigation and then come to the less relevant investigation.
Usually local potential.
So that is cardinal or even more important than that in MSc, which is the investigation? MRI brain. MRI brain. MRI brain, the significant lesions should be more than 6 mm, and the lesion should be periventricular, juxtacortical, brainstem, cerebellum and spinal cord. In these areas, the lesion should be there. So he has undergone 3 or 4 MRIs, which are showing all the lesions: spinal cord, brainstem, cerebellum, everywhere. Okay. So MRI, you will do it. Then the next investigation, what you told? Visual evoked potential. The evoked potentials. Evoked potentials are nothing but the brain, the electrical potential, which are computer averages. The brain electrical potential, the computer will average due to the evoked repetitive stimulation of the sensory nerves or the brain. What they do is checkerboard, they will give black and white checkerboard, they will give to the eyes. That will be stimulated. Then how much it is carrying the evoked potential. Okay, any latency is there in carrying the impulse, they will check it. In optic neuritis, there will be a problem with the visual evoked potentials. Yes, undergone visual evoked potential, which is showing delay. Which is showing delay at that time when he had optic neuritis. So visual evoked potential you can do, brainstem auditory evoked potential you can do, somewhat of sensory evoked potential also you can do. Evoked potentials. MRI evoked potential. Next, CSF. What are the things to see in CSF in multiple sclerosis? Okay, tell the first the cardinal thing what you will see and then come to the other rare things. Oligoclonal bland. More than 2 oligoclonal bland is in more than 75% of the patients. Then it is an autoimmune disease, multiple sclerosis. There will be intra-CSF, intrathecal IgG synthesis will be there. So IgG index. What is IgG index?
CSF IgG to albumin to the IgG to albumin in the serum.
Serum. That is IgG index. CSF IgG divided by albumin in the CSF divided by serum IgG divided by serum albumin. That is the ratio. IgG index. Then CSF analysis you told mild pleocyte is probably more than 5. If it is more than 75, if it is more than 100 proteins, more than 75 cells, polymorphonucleosides, think of other diagnosis. Okay, then it won't be usually multiple sclerosis. If more cells, if more protein is there. Okay. So what is the criteria, McDonald criteria apart after seeing all these MRI investigations? In T1 MRI imaging, you may get a black holes. What are black holes?
Axonal loss.
In a T1 MRI image, you may get an axonal loss show as a black holes in MRI. Okay. McDonald criteria. See the diagnostic criteria for multiple sclerosis. There should be 2 symptoms plus 2 signs in anatomically non-contiguous area. He has not 2, 3 or 4 symptoms, and even he has now only he has 3 signs. Nystagmus, biciplus, plantar extension. Anatomically non-contiguous area. One cranial nerve, one cerebellum, tandem walking, one corticospinal tract. So 2 signs plus 2 symptoms in the anatomically non-contiguous areas. Suppose if one sign is there, then the other sign could be a MRI finding or a above potential or a oligoclonal. Okay. Or if only one sign or symptom if you get, dissemination in space can be due to the MRI finding, or it could be one more clinical event. Dissemination in time could be by a MRI finding or a oligoclonal band. Okay, even if one symptom is there, one sign is there. Other can be substantiated by MRI, above potential and oligoclonal bands. Okay. Suppose the symptom is progressive for 6 months. Okay, then if intrathecal, if CSF IgG, if you document, then there is a primary progressive variety of multiple sclerosis. This is in brief, the McDonald criteria. In 2017, they made some modification to the McDonald criteria. Some cardinal features of that modification is the brainstem and spinal cord. Now you can take as a 2 spots, other 2 events as a dissemination in time and space. Earlier, both brainstem and spinal cord, 1 event they used to take. Now you can take brainstem and spinal cord as a 2 separate dissemination in time and space. And if oligoclonal band is there, you can take as a dissemination in time. If MRI is there, finding you can take as a dissemination in space. Okay. And earlier they used to take only juxtacortical lesions. Now even they take cortical lesions also. These are the 4 modifications. MRI and spinal cord 2 separate. If oligoclonal band is there, it is a dissemination in time. If MRI finding is there, dissemination in space. Juxtacortical they used to take, now even cortical lesions also they take. This is a modification of the McDonald criteria of 2017. So these are the investigations you do it. Okay. And you diagnose it. He has undergone MRI, he has undergone visual above potentials. Okay. All are fitting into multiple sclerosis. What are the other demyelinating disease differential diagnosis you can think in him? I'll tell that disease. Can you tell what are the point for and point against? ADEM. Can be ADEM?
There is no preceding vaccination or infection.
Yeah. So usually it will be preceded by a viral infection or a vaccination. ADEM. Age of onset?
Children
5 to 15 years. He is in 20 years. Multiple sclerosis 20 to 40 years. ADM is 5 to 15 years. Okay. Then
fever, meningismus,
coma, seizures. Fever, meningismus, coma, seizures will be there in ADEM. Correct. Then they'll have hemiparesis, quadriparesis, quadriparesis, brainstem involvement. And if you see ADM patients, there will be a bilateral optic neuritis. Usually, he has a unilateral optic neuritis, left side, and extensive complete transverse myelitis. In this case, he had a partial transverse myelitis. He had a bilateral motor weakness. Okay, and then there was a involvement of only the fine touch, below the level of hip, only fine touch at that time, not involving the pain and temperature. Like that, patchy transverse myelitis, what he had is a feature of multiple sclerosis, whereas complete transverse myelitis is a feature of acute disseminated encephalomyelitis. There will be complete transverse myelitis and bilateral optic neuritis, and oligoclonal band will be negative in ADEM, and they will have a more pleocytosis. CSF cells will be more than 200, proteins will be 50 to 150. These are the different features of ADEM for multiple sclerosis, and it is monophasic, non-progressive ADEM. But here it is coming and going, relapsing and remitting. Earlier, this patient they thought as a ADEM only. If you go through the files, previous files in all the hospitals, they thought ADEM only initially. But it is coming and going. The ADEM is a monophasic, non-progressive. So it cannot be ADEM. Okay. What is Schilder's disease? Schilder's disease is one more demyelinating disease of children 5 to 15 years with extensive demyelination of the cortex. And what is Ballo's concentric sclerosis? There will be a demyelination, normal brain. Demyelination, normal brain. So they'll have a normal and abnormal demyelination of the brain, giving a bullseye appearance. Ballos lamellar concentric sclerosis. Ballos concentric sclerosis. The one more important thing in him which you have to consider is with the transmyelitis and optic neuritis, what is the disease? Loud. Neuromyelitis optica. You have to consider. Okay. What are the criteria for neuromyelitis optica? Why it cannot be neuromyelitis optica in him? Yeah. So aquaporin 4 antibody should be positive. They have evaluated for him. Aquaporin 4 in him is negative. There are criteria for neuromyelitis optica. There are two sets. One is aquaporin positivity, aquaporin negativity patient. In aquaporin 4 positive patients, the criteria is they should have one core symptom. The core symptoms are optic neuritis, transverse myelitis, area postima involvement, brainstem involvement, then either narcolepsy or diencephalic involvement, and also the cortical features. These are the core criteria. Out of these core criteria, there should be one core criteria plus aquaporin 4 should be positive and other diagnosis should be ruled out. Then it is a neuromyelitis optica. Suppose if aquaporin 4 is negative, then they should have a two core criteria. In that two core criteria, one core criteria should be optic neuritis, transverse myelitis or area postima involvement. MRI should be having a dissemination in space and also they should have other diagnoses to be ruled out and aquaporin should be negative. Dissemination in space, MRI features should be fitting into the neuromyelitis optica. Okay, so you divide into aquaporin for positivity, negativity. Positivity, one core criteria is enough. In a negativity, two core criteria should be there. After those two core criteria, one should be of those three. Area postima, optic neuritis, transverse myelitis. Neuromyelitis optica also there are bilateral optic neuritis and extensive transverse myelitis. Long extensive transverse myelitis. Here is unilateral. Okay, and moreover aquaporin is negative. Okay, so you cannot think of a neuromyelitis optica. These are some of the close differential demyelinating diseases, Schilder's disease, Ballos concentric sclerosis, ADEM, neuromyelitis optica, which you can consider. Now he will ask you as a doctor, you are a doctor, is a patient, what is my prognosis? He will ask you. What are the things which indicates bad prognosis? What are the things which indicates good prognosis in multiple sclerosis?
Good prognosis is optic neuritis.
Optic neuritis.
Symptoms at the onset.
Sensory symptoms at the onset.
And there will be progressive minimal impairment after 5 years.
Minimal impairment after 5 years. And less than 2 relapse in the first year. Less than 2 relapse in a first year. Minimal impairment after 5 years. Involvement of the optic, involvement of the sensory symptoms indicates it is a good prognosis. What are the bad prognosis? Truncal ataxia.
And gait
tremors. Truncal ataxia, intentional tremors. Then corticospinal tract involvement, stiffness and progressive from the onset. Okay. So progressive from the onset, involvement of the corticospinal tract, truncal ataxia, intentional tremor if indicates it's usually a bad prognosis. One more thing in MRI, what is Dawson's figure? I just forgot to tell.
There is demyelination perpendicular to the periventricular surface.
Periventricular surface, there will be a perpendicular lesions. Dawson's figures will be there. A very important MRI feature of a multiple sclerosis. Just to conclude the case discussion, we should know a little bit about the epidemiology. What age group it comes usually? Multiple sclerosis. Which countries it is more common? Temperate and highly developed countries. But in India also nowadays, because of the socio-economic condition is improving, we are getting a lot of cases of multiple sclerosis. Some etiologies which they have postulated is Epstein-Barr virus, smoking, vitamin D deficiencies. Probably some etiologies which they are thinking. Okay, students, now we have discussed the multiple sclerosis, the diagnosis, prognosis, clinical features, examination, everything. Let us come to the treatment. How do you treat acute attack? and you name the disease modifying agents. How do you treat an acute attack of multiple sclerosis?
Glucocorticoids will start in acute attack.
Methylprednisolone you can give 1 gram for 3 to 5 days you can give to treat the acute attacks. Acute attacks you can also treat by doing plasmapheresis. Can you tell the disease modifying agents which you can give in multiple sclerosis?
Fingolimab,
Interferon beta first, interferon beta, glatimer acetate, mitaxantrone, fingolimab, natalizumab,
fumarate,
ocrelizumab, teriflunomide,
alemtuzumab,
dimethylfuranate, alemtuzumab. These are the disease modifying agents. You repeat?
interferon beta, in fingolimab, glatimer acetate, dimethyl fumarate, alemtuzumab, natalizumab, ocrelizumab.
Okay, dimethyl fumarate. These are disease modifying agents which you can try it. Okay. So he has been treated with methylprednisolone I think 2 or 3 times. Okay, and these are disease modifying agents also, and even rituximab also they are trying for a next episode on him. Students, one more variant which I forgot to tell is a Marburg variant. It is a tumefactive multiple sclerosis. The demyelination is so extensive that it appears like a mass, a demyelinating mass, a tumor. It appears like a tumor and the prognosis is very bad. Within months and 1 year they will die. That is a Marburg variant of multiple sclerosis. So this is a detailed discussion about the multiple sclerosis. We are lucky to have a very nice case of MS with so many signs and symptoms. So students, all of you go back and read about MS. Okay, next class will take one more interesting case of central nervous system. Thank you.
Advice TRP.
Hello students, we discussed detail about the multiple sclerosis case. So I want to just discuss the MRI findings in multiple sclerosis. MRI is the very important test in multiple sclerosis. Almost you can consider it as an investigation of choice. Okay student. So here you can see the hyperintense lesions, okay, suggestive of demyelination, okay. The hyperintense lesions which are perpendicular to the ventricles are known as a Dawson's figures in a multiple sclerosis. Usually these hyperintense demyelinating plaques will be seen in the cerebellum, the corpus callosum, brainstem and spinal cord, okay. More than 6 mm, these hyperintense plaques usually seen in corpus callosum, cerebellum, brainstem and spinal cord. Especially in this anterior part of the corpus callosum, if the hyperintense lesions are seen, that is very highly specific for multiple sclerosis. Okay, students. So this is a nice picture depicting the hyperintense lesions, the plaques, demyelinating plaques in the multiple sclerosis. Okay, students. Right. Thank you.